Next up, we have Dr. Keidan. Dr. Keidan is an internal medicine doctor by training. He's also the chief medical officer here at Boulder Community Health and my boss. Dr. Keidan is such a great partner for trauma and has supported us in our growth and really is one of our biggest cheerleaders. So we really appreciate his contribution to our practice here.
Thanks, Laura, and thanks, Robert, for that great presentation. Reflecting about the presentations we've seen so far from Dr. Vissers, Dr. Goldman, Dr. Gross, and Dr. Shapiro, I'm an internist, so I'm just like overwhelmed at the expertise we have in this room. And then I'm looking around and I see like paramedics, nurses, multi-specialty physicians, PAs, NPs, administrators, therapists. It's really amazing. So I'm so proud of this team and whatever limited involvement I get to have. And I also think it's important, when Laura and I were talking about what we want to accomplish at this symposium, it reminded me that trauma is hard. Like, this is hard work. Seeing some of those pictures that we've been seeing, fortunately some of them had really amazing outcomes, but they don't all. And so I just wanted to take a moment to reflect on that and thank all of you, because all of you who are caring for these folks from the beginning, pre-hospital to post-hospital, it takes a toll. So I think it's really important just to thank you. So I just wanted to sort of give you a little appreciation. And so as Laura said, I'm an internist. And so you may be wondering, like, what do I have involved in trauma? Like, why would you, need an internal medicine doc? And I felt the same way when I started going to the trauma meetings about 7 years ago. And when you go to these trauma meetings once a month, you get a group of multi-specialty surgeons, general surgeons, orthopedic surgeons, neurosurgeons, paramedics, emergency medicine, radiology, anesthesia. I mean, it goes on. It is one of the biggest multi-specialty teams I've been privileged to be a part of. And they really work like a high-functioning team, and a lot of that has to do with the trauma team who's in the back, who sort of coordinates it all and gets us data and allows us to do interventions, quality improvement. And so that's where, as an internist, I've done a lot of primary care, hospital medicine, quality improvement, substance abuse, and palliative care. And so you'll see that there's two real main things the way I look at trauma. One is this multi-specialty expertise, acute care. It's so important, and we crush it. I think you can see that. And so much that we're only having like a handful of our experts talk because, there's always next year. There's just so many amazing people that aren't all getting an opportunity to talk. But you also need this system of care. And I think I'll show you there's a little bit more involved than just the acute trauma. So we're trying to do both, and we're trying to do them really well. And so I wanted to kind of just go through like how we got there and where we're going, just from like the bird's eye perspective. And I promise you I won't show any gross pictures, and there won't be any like major medical facts you'll have to learn. You can see the hospital started just about 100 years ago as like a small little hospital, 15 beds. At the time, a few physicians and nurses and caring for a small group of patients. Over time that grew. You can see that in 25 we had this larger hospital, 45 beds. Then you can see the Broadway and Balsam, the one that I was at when I first moved here 20 years ago. And a couple things I'll point out. In the 60s, that's when trauma programs first emerged. This idea that you need a system of care and that communication across huge teams is really important, and that improves outcomes became more apparent. In the 70s, I just looked this up because I was like, did they even have ER docs back then? And in the 70s is when ER became a specialty. So you went from this community of general practitioners, general surgeons, nurses, to this like more specialized care, which is, I think, more of like an example of how medicine has gone over the last 100 years, particularly in the last 20 years. In 96, we became our first trauma designation at BCH. And then we moved to Foothills in 03. First it was a 60-bed kind of OB hospital, peds. And then in 14, we moved out of Broadway and we got our level 2 trauma designation. And so I think most of you know this, but there's level 1, 2, 3, and 4. Level 1 is the highest, and that's really for academic research organizations. That's really part of the mission, so you can't really become level 1 unless you have that. Level 2 is the highest you can get at our size community hospital. And then there's 2 designations for level 2. There's the state, which is a little bit easier to attain, a little less resource intensive, and then there's the American College of Surgeons, which is like the elite of trauma programs. And it took us a while to become ACS certified because it required a lot of investment in resources, which we did eventually get. In 2021, we became American College of Surgeon designated. Why does that matter? Because the American College of Surgeons, as the leaders in this field, they have all these rules and requirements, and as an administrator, they sometimes seem expensive, sorry, Rob, and frustrating, but looking back, they've greatly improved the care. So a couple things, they require 24-hour in-house trauma surgeons. That, I apologize to the trauma surgeons because that is disruptive and difficult, but it greatly improves the care of our patients. We also had to bring anesthesia in-house 24/7, which also improves care of like our OB patients and our other patients in the hospital. And then we brought in a traumatologist. Dr. Harmon is our first general surgeon traumatologist, so specialty trained in trauma. And then you saw Dr. Gross, and what you get when you get an orthopedic traumatologist, really an expert in orthopedic trauma, to partner with the rest of his team. And then in 2023, we added a geriatric trauma medical director. I saw her, there she is waving, Liz. She's gonna talk to you later. And you're gonna be like, why are you having a geriatrician? But I think you'll see why in a minute. She's gonna talk later, and I think you'll like that. And then in 24, we're looking at bringing in palliative care, trauma surgery, and expanding vascular. So see, these are some of the things we're doing. So we're responding to this specialization of medicine, which it's sort of overwhelming when you see this facial trauma and cardiac trauma and all this stuff. And so I thought, before I went further, I would just sort of maybe take a little audience participation, because we've seen a lot of the examples of trauma. And so I just wanted to ask, what is a trauma patient? Like, maybe just yell out. What type of patients do we see? Cyclists, yes. In Boulder, we see a lot of cyclists. Let's see, Tyler's gonna help me out here. So we have a lot of cyclists. I'll get to those stats today. And those are the competitive cyclists, but you see a lot of like casual cyclists like me, and I worry about every time I ride my bike to work that I'm gonna be on the trauma team, not as a provider. What else? Climbers. In Boulder, we've got quite a bit of climbers. There you go. What else? Say again? Skiers. We don't have a skier, but yes, we have all sorts of athletes, especially in Boulder. We have all these like outdoor athletes. What else? Car accidents. Is that what I thought? I thought that was going to be first, car accidents. We see a lot of car accidents. What else? Okay, motorcycle. Why is Liz Lysette here? Does anyone know? Why do we see geriatrics in trauma? Falls, right. That's 5, Tyler. And what about, people sometimes notice in Boulder that we have a lot of disproportionate, we have some wealthy and we have homeless, et cetera. Do we see homeless patients in trauma? And then, I can't remember what 2 is. No, Tyler, help me out here. Oh, there we go. We see elite athletes, football players. In fact, we had a few this year. And I think it's interesting because I think we often forget the geriatric trauma and the homeless patients. And I'm not trying to lump them all together, but substance-related issues, alcohol and drug. And I think those of you who take care of these patients, you don't forget that. You know this. But those are actually the biggest proportions of the patients that we see. And so when you start seeing that, you start thinking about trauma a little differently. And I think I put some stats here. So more than half of our trauma patients at BCH are geriatric. The majority are falls, not all. Some are motor vehicle accidents and other things. And I was shocked to see that almost 3/4 have some component of substance abuse or alcohol. And then I wasn't sure, but 15% are, I guess you could call it recidivism. They're returning trauma. And I once read about trauma. It's sort of like, I think obesity can be seen like this. It's sort of infectious, like people that have trauma tend to get it again. I thought it might be higher. And so I'm a population health quality person, that's my background, and so I start thinking about trauma a little more broadly. When you look at this, you start to think, what could we do to prevent trauma? Geriatrics, maybe there's fall prevention, maybe there's changes in meds, reducing high-risk meds. Liz is going to tell us more about that. And when you think about substance abuse, you think about prevention and treatment. And one of the most obvious things is people that with trauma, with substance abuse, in the past would just sort of languish in the hospital in withdrawal. And now we have new treatments like medical-assisted treatment for opioid addiction. And so you can really take an angry, uncooperative, difficult patient and make them this sort of a compliant patient by putting them on treatment. And so we started doing that, 5 or 7 years ago, and offering, for example, people that are addicted to opioids medical-assisted treatment while they're in the hospital, both to take care of them acutely and then to hand them off to our partners that do long-term substance abuse treatment. So we're trying to think about this a little bit more broadly from a quality improvement perspective. And so I just put a little plug for a couple of our programs. Where's Amanda? I saw her earlier. There she is. There's Amanda Werblowski. She's our pillar manager. This is a grant-funded program initially through the city of Boulder, now through our foundation, and then BCH funds this. But this is a program we have to help navigate, provide access to treatment and prevention for people that have substance abuse, so that when we do have trauma patients, we're not expecting the trauma surgeon or the ENT to be an expert in this. But fortunately, one of the things we learned really early, was that we have a lot of people that are experts, and I think there's some of them in this room, that are willing to treat these patients, and they're great at it. And so we started working with these patients and making sure if they wanted it, they had access to treatment. I'm glad we're not in COVID times and not all wearing masks. And then the Trauma Survivors Network. This is cool, and before I get to it, I'm just going to tell a story. I visited a trauma patient the other day. I'll just call her Jill. She's 27. Some of you were involved taking care of her. It was pretty traumatic. She was biking with her husband to the rock climbing gym. Pretty healthy woman, never really had medical problems from what I could tell. And she got hit and run and dragged about 100 feet by a car. And she had some significant injuries, multiple orthopedic injuries, multiple neurosurgical injuries, a lost tooth. She was pretty messy. So I went and saw her first in the ICU, and she couldn't really talk, and her husband and I chatted a little bit, and she was just recovering. And then I saw her yesterday, and she's getting a lot better. And the first thing, I introduced myself, and I just asked how she was doing and how the care would, and she started to cry. And she said to me, "I can't believe this happened to me. Like, how did this happen? And when am I going to get my life back?" Like, she's talking like she's going to go to long-term acute care and then rehab. She might be months until she gets home. And I felt proud that over the last year, where's Sadie? Sadie's here, right? Yeah. Sadie's one of our trauma team members who's spearheaded this Trauma Survivors Network, because I think, as Dr. Goldman was talking about, trauma has external injuries, it has internal injuries, and it has emotional injuries. And we're trying to make sure that, when you look at some of these patients, you can only imagine how traumatic that must be emotionally. And so this is one way that we get, I think now there's 10 patients in a room, and they get to sort of talk about the trauma that they're experiencing, what's worked and what hasn't, and there's a little bit of a support for them. So I think this is just one way we're trying to treat trauma more as a system and more, end to end. And then the last thing I want to do is recognize, and then I'm going to turn over to Jackie Atlas-Priest, she's the Chief Nursing Officer, I'm the Chief Medical Officer, together with the administrative support for the trauma team. And as you've seen, trauma is a team sport. I'm going to focus a little bit on the physicians, and Jackie's going to talk about the nursing and the rest of the team. But the together is crucial. You can't do one without the other. And this team is pretty darn amazing, and I like to say any one of these medical directors or nursing leaders could go anywhere at a level 1 or level 2 trauma center in the country, and they would get hired, be program director if they wanted. In fact, they're often trying to steal them. We have a really amazing team. I think you've seen that. I wanted to just call out some past leaders. Dr. Jones, Charlie Jones, all of you know him probably, was our trauma director for many years and still on the trauma team providing care. My predecessor, Dr. Paul Lewis, was the chief medical officer and an ER doc and really dedicated to trauma and helping us get to level 2 trauma and really had a passion for trauma. And then 2 of our key nursing leaders, I think Jackie's going to talk about, so I don't want to steal her thunder, but Holly Peterson, who was our trauma nursing director until recently, and Joan Palin, who really kind of, I would say, got me involved in trauma and started telling me what I needed to do and helped me learn how to manage trauma. And then our current program, you've seen Dr. Harmon. She's in the way back. Obviously, she's done an amazing job in getting this group together, getting this symposium together, bringing all the right players. The best thing I can ever do is just hire good people, and that's a great example of that. Dr. Marthaler, is he still here? I saw him. He's our associate trauma medical director. Lisa Allen is one of our nursing directors. I don't think I saw her. And Josh Rabinski, who is the trauma manager. And Jackie will talk more about them. I don't want to leave them out because they're pretty amazing. And then we have many trauma medical directors, and we have many people I'm leaving out, so I can't acknowledge everyone, but I wanted to acknowledge some key folks. Steve Gross, you saw him speak earlier, really upped our game in orthopedic trauma management, and these pelvic fractures was like sort of it was really like a bugaboo, like we didn't really have a great way to manage those until Steve got here. And that, amongst many other things, has really helped us manage orthopedic trauma. Dr. Lysette, I mentioned already. And then Dr. Sovendell spoke last year. He did a great job last year. I wish he was speaking again. He is a pretty amazing ER liaison, and he also manages a lot of the pre-hospital paramedic groups. He's their medical director. An amazing asset. I think many of you know him.